Arthritis Unpacked is an independent patient education resource supported by Janssen. The information provided is for educational purposes and does not replace advice from your healthcare professional. Paul Bird is an experienced rheumatologist and researcher, dedicated to the expert management of patients with all forms of arthritis and rheumatic disease. As well as caring for patients in his clinical practice, he continues to undertake arthritis research with fellow Australian rheumatologists and with international colleagues, ensuring he is up to date with the most recent medical advances.
Welcome to the fourth episode of Arthritis Unpacked, a video series designed to help you understand your arthritis better and help you get the best out of your treatment. Join me, Dr. Paul Bird, an arthritis specialist, which is also known as a rheumatologist, as together we unpack your arthritis baggage, helping you navigate the maze of arthritis terms and treatments. Arthritis without the jargon, arthritis made simple, arthritis unpacked. Today we're going to talk about rheumatoid arthritis treatments. Let me introduce an important concept right away: relief of symptoms and prevention of disease. Now, this is not my concept, it's a concept that the asthma world uses all the time. Many of you would know people with asthma. They get short of breath and they have two types of puffers to help manage their asthma. One type of puffer is a reliever, that's like Ventolin or salbutamol. They get short of breath, they take some puffs on it and it relieves the shortness of breath. The second type of puffer is a preventer. This is designed to be taken regularly and stops the asthma symptoms coming on. Now, you will know people with asthma who use a preventer and sometimes have to use the reliever as well at the start of their treatment journey, but once controlled, they generally keep the preventer going, using the reliever only as needed if the asthma flares up. Let's take that concept across to inflammatory arthritis, and in this case, we're talking about rheumatoid arthritis. The first thing that I need to do for that patient in front of me is relieve their symptoms. They need to live their life now. They need to be getting back to normal as quickly as possible. So the first thing that I'm going to talk to them about is providing relief from symptoms. I'm going to use relievers. They include anti-inflammatory medications like Nurofen, Voltaren, Naproxen, Mobic, just to name a few. And I might suggest some painkillers as well, like paracetamol or acetaminophen. If the inflammation levels are really high, I might use a powerful anti-inflammatory called cortisone by tablet or injection. Cortisone, also known as prednisone, prednisolone or Panacort, is used for short to medium periods of time, days to weeks, to control the inflammation and give symptom relief. I'll do that to wrestle the disease to the ground while I work out which preventer is going to be best for you. So, relievers first, and usually at the same time, I'll start another medicine as the preventer, just like asthma. And once the preventer is working well, you won't need the reliever as much. Remember, relievers relieve the symptoms. The main examples are painkillers, non-steroidal anti-inflammatory drugs like Voltaren or Mobic, or cortisone. Most people with rheumatoid arthritis are going to need a preventer. The relievers on one side will help for a bit, but if I don't get a preventer on board, the rheumatoid arthritis is going to come back when I take them away. So the reliever gets on board, we get the person feeling better, and then we get the preventers into the system. Let's talk now about the types of preventers we use in rheumatoid arthritis. By the way, I cover different medicines or therapy in a whole separate podcast episode in much more detail, but in this episode we're going to talk about broad categories to give you an overview. The preventer medicines in RA fall into three main categories. DMARDs, which stands for disease-modifying anti-rheumatic drugs. DMARDs are the most commonly used and studied drugs used for therapy in rheumatoid arthritis. These have been around for a long time, and rheumatologists will generally go to these first as they have really good proof that they work in a large number of patients. Let me name four main drugs in this group: methotrexate, hydroxychloroquine, also known as Plaquenil, leflunomide, also known as Arava or Arablock, and sulfasalazine, also known as Pyrrolin. They are all tablets and they all take some time, anywhere between 6 to 12 weeks to do their job. So you'll probably need a reliever while these are getting going to do their job. Sometimes we use these in combination initially, for example, methotrexate and leflunomide to get better protection for you. Let's unpack category number 2 in the preventers, biologics. Biologics are special drugs that target specific inflammatory chemicals that are being overproduced in patients with RA. They are given by injection or infusion because if you take them in a tablet form, the stomach acid stops them from working properly. Most times your rheumatologist will try a DMARD first for 3 or 4 months or so, and then they'll move on to biologics if the DMARDs aren't working. Fortunately, today there are a few different types in this category. TNF inhibitor biologics. TNF inhibitor biologics work by targeting something called tumour necrosis factor proteins, or TNF. TNF is a protein that sends signals to your body, eventually leading to inflammation that causes swelling, pain and stiffness. By inhibiting or stopping TNF, these medicines reduce inflammation. That's why they're often called TNF inhibitors or TNF-I. Some common TNF inhibitor biologics are adalimumab, also known as Humira, sertolizumab, also known as Cimzia, etanercept, also known as Enbrel, golimumab, also known as Simponi, and infliximab, also known as Remicade. Non-TNF inhibitor biologics. Some biologics work differently than blocking TNF inhibitor, and these include abatacept, also known as Orencia, rituximab, also known as Rituxan, and tocilizumab, also known as Actemra. All of these work by blocking specific parts of the immune system and all have the same goal, getting the immune system back onto standby where it belongs. Let's take a breath. So many names, so many options, but it's all designed to make sure you have lots and lots of options to get you on the path to wellness. You won't have to go through all of these medicines. Your rheumatologist will guide you to the best combination for you. Let's unpack the final category of preventer medicines, the Janus kinase or JAK inhibitors. JAK inhibitors are a new class of arthritis drugs that treat rheumatoid arthritis. They are known as small molecule medications and they come in a pill form. These are as effective as the biologics and are usually used after the DMARDs. Your rheumatologist may even prescribe this drug before you try a biologic if he or she thinks it's the right option for you. Examples include baricitinib, also known as Olumiant, tofacitinib, also known as Xeljanz, and upadacitinib, also known as Rinvoq. Phew, that's a lot of unpacking. Let's just take a moment to review what we've just gone through. Remember, treatment is designed to get you back to a state of wellness. One of the things I say to patients with rheumatoid arthritis is that our aim of therapy is to get you back to the point that you walk through my door and you have no or minimal symptoms, and there's nothing that you can't do because of your arthritis. We set that goal early. That way we both know which bar we're trying to reach, and to reach that bar, we have to use medicine. And I want you to remember those concepts that we went through. The concept of relief therapy, like anti-inflammatories and painkillers that relieve the symptoms, and prevention therapy that aims to turn the illness off and restore you to wellness. While to some it may be confusing that there are so many prevention therapies available, I think that just tells you how complex rheumatoid arthritis is, and also shows you how far we've come in treating it. As you know, rheumatoid arthritis is different for every person. Everyone requires slightly different tailored therapy, and we're blessed with many options. Certainly several more than when I set out to help patients with arthritis. Now, while the medicine is working, there's a lot that you can do to help. Diet, exercise, and reducing stress are all important parts of the treatment for arthritis, and we'll discuss those in the next episode. I'm Professor Paul Bird, and this is a video series all about arthritis. Without the jargon, arthritis made simple. Arthritis Unpacked.